Thank you for giving me the opportunity to talk about something that I think is really interesting and kind of helping us move forward and treating more complex patients with endovascular procedures. I have the real pleasure to be able to have a room that gives me a lot of these opportunities, and I'll share some of my experience with it. I am on the regional advisory board for Medtronic. I don't have anything specific to Medtronic in these slides. The goals and objectives, we'll talk a little bit about the principles of image fusion and specifically of 3D image fusion. We'll also talk about the procedures to actually perform image fusion to try and make it seem approachable to everyone, because I think it is a very approachable technology that a lot of people do have access to as they get new hybrid rooms. Talk a little bit about the learning curves and some tips and tricks that we've learned over time. And then we will discuss a little bit about the data around the use of image fusion and its utility in kind of complex repairs and routine repairs as well. Try and keep this brief for you guys. Kind of talking about it, the first papers that really talked about image fusion actually came out of Roy Greenberg's group, and so out of Cleveland Clinic. And this was back in 2010. They talked about using cone beam CT to fuse the images, the preoperative images, to the cone beam image that was taken in the operating room to create a fusion image that you could then use for performing your procedure. Now that obviously was a larger dose of radiation than what we currently use, but this really opened the door to this idea. It did require doing a cone beam CT prior to performing your procedure, but they showed that even with this, they were able to achieve lower doses of contrast, and they had a trend toward lower radiation dosing in their 40 patients that they reported in that paper. Since that time, it really has evolved a lot from the idea of using a cone beam CT, so an on-table CT with your hybrid C-arm, to now performing 2D to 3D registration with just using two single images in orthogonal planes, meaning an AP and a lateral, or what I would advocate for is 245-degree LAO RAO projections to be able to get a good overlay of your bony landmarks, which then allows you to fuse your preoperative CT scan to the patient on the table. The benefit of using that, as opposed to the original description that Dr. Greenberg and others had described, is that it's significantly less radiation to just have two fluoro images. It's fast, it takes only a couple minutes to do that portion of it, as compared to doing a cone beam CT and then processing the cone beam CT to create the images and then fuse them, which took about 15 to 30 minutes. So it's a procedure that's really made it much more approachable. The image fusion platforms are currently available on 3 of the major systems, and I actually believe there are several others as well, but these are the ones I know for sure have a very functional image fusion platform. I've used all 3 of these, and they're all very similar. They all have their pluses and minuses, but they all will get you to where you need to get if you want to do it. So the Siemens, whether you're using their platform now, that's an excellent platform to have image fusion. Philips, again, with both their robotic arm and in their regular, again, have the ability, and then the GE platform as well. There is a freestanding software program you can use, which uses artificial intelligence, called CITER EV. I don't have the cost on that. I've not actually used it, but they do have that, and that is something that can be merged with your existing platform to be able to give you fusion images. And the benefit of that one is that instead of manually registering, meaning aligning your patient image with the CT scan from beforehand, they actually do it with artificial intelligence to kind of mark points and be able to move it to put it on the patient. They also have some kind of interesting software that allows it to kind of account for the stiffness changes when you put in stiff wires, so that you can do this as well. When we think about image fusion, the question is really, is there a reason to do it? And I got an argument about this with Ben Starnes. He's a big advocate for that it's a waste of time. I think there are a lot of us that believe it is a useful thing. And there actually have been a lot of papers written using fusion imaging. There was a meta-analysis that was performed just in this past year, and they looked at 11 studies in this meta-analysis And really what they showed was that there's a significantly lower use of contrast if you use fusion imaging, whether it's in standard EVARs or in complex EVARs. In both cases, it was a significantly lower use of contrast. They also showed that although fluoroscopy times in the standard EVARs were not significantly different, in complex EVAR, it did significantly lower the fluoroscopy time. Now, fluoroscopy time is a proxy, right? It's not the real, really important measure, which is more of a radiation dosing. Radiation dose was not significant. It was approaching significant for standard EVAR, and for complex EVAR, it was just about significant as well. And so in both cases, they weren't quite there, but it seems to be a trend toward a lower radiation dose overall. And then in procedure time, and this one again did show a significantly lower procedure time if you're using fusion imaging for each standard or for complex EVAR. So my takeaway from that is that it lowers your contrast dose, which I'll agree with. And then I think it also does lower your procedure time because it gives you a roadmap. It gives you something to use and to look at and to cheat a little bit. And so I think those are true. Whether it lowers your radiation dosing, I think there are a lot of other things you can do to lower your radiation dose on top of this that may also kind of compound how effective this is for doing that. But I think it's a useful tool. So kind of going through image fusion, I'm going to show you how it's done on our system. So we have a Siemens system, the Siemens Pheno system at U of M, which is a nice robotic arm. This system is also available on their ceiling mount system that's out now as well. And the first steps of this are really creating reference images. You have to have a bone reference and an aortic reference. And what that means is you segment, you remove either the bone or the other structures to give you two images. And these two images are going to be used as your roadmap. This is really what is getting registered, meaning aligned with the patient on the table. And so really what you do is you align those two, and then after you've kind of created those two, you have to go through and then mark the things that you want to mark so that you can kind of put them up on the screen. And this is, in my case, what I do. They do have automated packages for this, but I honestly think that the automated packages are not as good as doing it by hand. And if you practice doing it, you can do this in less than 30 minutes. And you just sit down and you mark out the renals, the SMA, the celiac, the iliac bifurcation, the aortic bifurcation. You can mark all these things with rings. You just draw a ring around each of them, and it gives you the ability to do that. Once you've done that, you can then get the patient on the table. This is all done before the patient's in the room. You can do it ahead of time. You put the patient on the table. Once they're prepped and ready to go, all you have to do is take two orthogonal still images, so just two fluoro images. I use 45 degrees and 45 degrees because I found that it gives a little bit better registration, meaning that we're able to line up a little bit more reliably using the iliac crest and the 12th rib as our landmarks, as compared to when you go AP and lateral. I found that interestingly, it's just a little bit harder to get the registration just right with that. And so I use 45 and 45. I know other people do differently. This is just an example of how you do that. You can see here, this is the fusion image that you see in color in the background. You can see the darker iliac crest there. And so we would slowly pull and drag the iliac crest so it's overlying so that we can get a good image fusion. And then once that's done, you have your baseline image fusion. Once you've done the baseline image fusion, you then have to kind of do something to ensure that you're able to confirm that the image fusion is close. So I usually will do a puff. I'll do a high injection for a very short duration, so 30 mLs per second for 7 mLs total. So you give a very high intensity but short duration puff of contrast at the level of the visceral segment. That'll illuminate your renals, and you're able to then drag the renal markers into those two spaces. Once you've done that, then you've kind of aligned in the visceral segment, which is the most important point, and you can put the device in. And so you can see here in this image, we have a device in. We're a little bit high on this side right now before deployment, but you're about ready with just 7 cc's of contrast. Or less if you're using half and half contrast, you're ready to then deploy your endograph with just one quick puff of contrast. Really, once you've done that, you're able to kind of adjust if you want to for the iliacs. But I think there's some really kind of some useful tricks and tips for doing this. You know, we've learned, having used it for the last 2.5 years on every case, that you just have to be patient. The critical part of this is the preoperative preparation. It's sitting down and making a nice, your two reference images, the aortic and the bone images. That's pretty easy. It's a mundane task that you can train your techs to do. You don't need to do that. And then creating the rings, the markers around your visceral segments or around any interest that you might have in that aorta. That really is also a task that you can train a tech to do if you have a reliable tech. I do it as well, just because I think it's a good exercise in kind of preoperative planning and really learning what someone's aorta looks like and thinking about what the pitfalls are going to be. But when I do it now, routinely creating both those segmented images and then the markers usually takes me less than 30 minutes. And then once you've done that, patient being on the table, you want to make sure to register the overlay on there is patient. It's a couple minutes, but in the end, I would argue that those couple minutes that you take to do that is going to save you much more than that on the other end of it. And I think that the puff of contrast, I've used that for a long time to confirm renal position. Using it now to confirm your overlay, which is always just a little bit off because you put stiff wires in, they're always going to be a little bit different. And even though the visceral segment probably moves a little bit less, the visceral segment may move a little bit less than some of the other segments of the aorta. It still will move, so you have to account for this. So you have to do some type of injection to confirm this. I will say, when you use the fusion imaging in the thoracic aorta, it's a very dynamic part of the aorta. I've found that there's a lot of vessel motion, which can make the fusion a little bit more difficult just because of that. It is still useful for marking your innominate, your left and your left carotid and your left subclavian, but just bear in mind that there is definitely a lot of vessel motion up there. So keep that in mind when you're using the fusion imaging as well. Just some examples of us using the fusion imaging here. In these examples, you can see we've just turned off everything except the rings once we've done our fusion. And you can see this is a patient where we've already deployed the endograft, and you can see that we've comfortably landed just below the renal arteries in this case. You can see we've marked as well where the iliacs would be. And what I will point out here is you can see the stiff wires and the stiffness of the endograft really change where those iliacs are. And that's the part I always notice, is that with fusion, your iliacs are going to be in a different position many times. Now, the bifurcation of the iliacs a lot of times is closer to where it is on the fusion. So if you mark your bifurcations, I think that's a little bit more useful. But that still can move as well with a stiff wire. And this is just another example of us doing a fenestrated endograft where we don't take any injections prior to putting the endograft in place. We pre-cannulate. I've pre-cannulated here since I started doing them. And we pre-cannulate the renals based on the fusion imaging. We then put our device in, we deploy, and then we recannulate again, having not taken one injection that whole time. And it really saves you a ton of contrast. It saves you radiation because you're not doing any DSA runs, and it gives you a real opportunity to really minimize that for the patient. Here's some examples again. This is a complex branched endograft that I was doing. You can see here we've marked out celiac, and a little bit further down on the celiac where the bifurcation would be is the second mark, the SMA. The first branch of the SMA, and then also the renals. You can see how you can use this to really give you the trajectory to be able to align and cannulate those vessels with minimal, hopefully minimal effort, but minimal use of contrast and radiation. So, and I'd say in summary, our use of fusion with Dr. Elias and I here, who use it routinely on 100% of our cases, we've really noticed a decrease in our radiation and contrast use. The average volume of contrast that we're using in our fenestrated cases is definitely less than 50 cc's. There are many times that we're less than 40 cc's or 35 cc's of contrast that are used for a fenestrated case. I did an endograft just yesterday where we used 20 cc's of contrast and had 14 minutes of fluoro time. So I think it really can markedly improve things. So I'm happy to take any questions about it. I really think it's a great technique. I'm really excited about it. I'd love to talk to anyone who has questions about how to deploy this at your site. if you want to ask me questions, reach out to me either now or offline. Oh,
Nick, there's a question in the chat.
okay, let's see here. So question about using IVUS in conjunction with the image fusion. I have used IVUS. Mostly I use IVUS in the thoracic aorta, not so much in the visceral aorta, but I think it's a good adjunct as well. And you could easily use this to mark your visceral segment and not use any injections. And I think that'd be fine as well. I am probably a little more impatient and then I just do a quick puff instead of using IVUS because it's pretty quick, and 7 cc's of contrast isn't very much. The learning curve, I think the learning curve for this is honestly not that long. It seems daunting the first couple times you make your, you do your registrations and you create your segmented bone and aortic models, and then you make your rings. But I think with a little bit of practice, I think you can get it down pretty fast. To being reliable where you trust your models to be able to put devices in with fewer contrast runs. I think if you do this for your first 10 EVARs, just standard EVARs, you'll see pretty quickly how easy it is and how reliable it is. And then you move on to doing it for your more complex cases and really trusting your ability to do this, and your fusion imaging has really remarkably decreased our contrast usage. So I think the learning curve, I think, is actually pretty short. The other part of it is that you can practice making your images as much as you want. You can it's just sitting at a computer. And so I think that makes it another part that's pretty approachable.
Nick, that was a really great talk. So I have a question for you. There's a code that is used for detailed preoperative planning. I don't know, have you ever used it, and you get reimbursed for it? So you're spending 30 minutes doing this, right?
Yeah. We have not used that code here. I asked our coders about it at one point, and they kind of dissuaded us, saying that was used mostly in radiology. But I think it's something to bring back. Our coders are very conservative about this stuff. But I think I know other sites that do use that code. I know that when I was talking with a couple of the providers at Cleveland Clinic, they had mentioned that they use those routinely, those codes. So I think it's worth thinking about if you're going to do it, and you have coders that are willing to kind of take that to bring that up as well. I think it'd be worth trying.
Yeah, because it's justified. You spend a lot of time planning for this, and not only that, but it's good for you and good for the patient, good for the team. You reduce radiation exposure, so it makes a lot of sense. So what would be fascinating is, to put Ben Starm's argument to rest, is to see if this decreases the operative time.
Yeah.
Because that will win the argument, right?
Yeah, no, I think so. I think there's so many things that go into your operative time that, you learn where you can cut corners in doing an EVAR. So I think that his argument is he knows what he has to do to be able to do a fenestrated or to be able to do an EVAR with minimal contrast and less time. And he'll tell you he can do it just as fast as anyone else. Now, is that true? I don't know. But, I'd agree with you. I think the best way would be head-to-head kind of comparing people, and the same person doing it both ways and seeing how it's done too, So thanks.
So we got 3 minutes before the break. Peter, do you want to say anything?
Looks like one more question for Nick. Appreciate the good feedback on that talk.
Yeah, the fellows and residents, some of them are very interested in doing this. So we have a chief resident who's graduating and going on to a faculty job at Florida, who has taken a keen interest in learning the technique himself. And so he has routinely tried to make his own. And so I think it's good practice. The great part about it is that, you can let people make their own marks, make their own models, and you can turn them on or off, and they're there, and it doesn't hurt to have them there. And so it gives them the opportunity to do it, and it doesn't hurt anything. So I think it's a good opportunity for them to do it. And it gives you just such a clear picture of someone's aorta. that I think it's a nice way to really teach people about aortic anatomy and to really think about the individualized patient too. So that's another